طيب I think it's a good time to start. السلام عليكم ورحمة الله وبركاته جميعا. شهركم مبارك على الجميع. عاد الله علينا وعليكم باليمن والبركات. تقبل الله منا ومنكم صالح الأعمال. Good evening all, and it's a real pleasure actually to be among you today and among our eminent speakers and authorities in the field. I'm very glad to be joined today by Dr. Saeed Al-Ghamdi who is a consultant nephrologist from King Faisal Specialist Hospital and Research Center in Jeddah, as well as Dr. Hussein Al-Badawi, consultant endocrinologist from my clinic and head of the metabolic unit in Jeddah. As you all know, and I'm very glad actually to see all these three arms in one session, sitting around virtually one table. Hopefully in future we'll be really on one table together, talking about such a very crucial and an important topic, especially in our community. We can all attest to the need of discussing such a topic. As you all know, diabetes is quite prevalent in our community, probably one of the highest in the world. And the complications of diabetes go without being said, whether it's cardiovascular complications, renal complications, and so on. But having such a forum to discuss these complications, specifically today talking about diabetic renal disease or kidney disease and kidney disease progression, is worth mentioning. Many of us can attest to that in our clinical practice, seeing many of our patients with diabetes with progressive kidney disease. And I might not be mistaken if I say it's probably the most common cause of renal dialysis in our community. So finding ways to prevent such progression and such disease, I think, is worth all the effort. Discovering new pathways and new ways of treating such patients, and as we said, preventing such disease from happening or progressing if it's a must to happen, is a very important topic to discuss. Today, I think we're going to be touching on a new pathway, a new modality of treating such patients. And I'm sure we won't have better speakers than the ones we have today, with all their experience in the field, to highlight such pathways and mechanisms in treating patients with diabetic kidney disease. Without further ado, I would like to introduce our first speaker, Dr. Hussein Al-Badawi, as I said, from my clinic in Jeddah, who is a consultant endocrinologist, talking about improving cardiovascular and renal outcomes in diabetic kidney disease. So please, Dr. Al-Badawi.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Walid, for the kind introduction. I extend my thanks to the organizing committee, as well as the sponsors of this event, who brought us all together virtually in a blessed night, inshallah, for a blessed purpose, as you had highlighted, which is to help our patients with type 2 diabetes protect their kidneys, protect their hearts, live longer, happier, and healthier lives. So my task is just to give you a quick introduction between diabetes and kidney disease, and how we can potentially protect the effects of diabetes on kidney disease. So the agenda, hopefully by the end of my 15-minute talk, we'll cover the burden of the disease, appreciate the importance of screening, how to screen, and then what we can potentially offer based on what guidelines. So to begin with, Dr. Walid already highlighted that diabetes is almost a pandemic. It is everywhere in the world. And the problem is it is increasing in prevalence as well as in incidence. With diabetes, complications come along. Chronic kidney disease is the main focus of today. So if we estimate based on the International Diabetes Federation Atlas, which estimated that there are probably 463 million adults with diabetes back in 2019, almost 10% of the population. And we estimate that out of these, 90% are type 2 diabetes, which leaves us with almost 416 million. Now, if we calculate the potential prevalence of CKD, we can say that we know that out of every 5 type 2 diabetics, we have 2 who are affected. Therefore, the prevalence is estimated to be around 160 million patients living with CKD in type 2 diabetes. That's a huge number, and that number is increasing. Now, why is that important? Well, we have learned statistically from epidemiological studies that as we move from not having diabetes and not having chronic kidney disease, if you have a diabetic, then you increase the 10-year cumulative incidence of cardiovascular mortality by around 6.7%, which is doubling from what the non-diabetic has. And if you have type 2 diabetes and CKD, we're talking about an estimated incidence of mortality by around 20%, which is almost 6 times higher than a non-diabetic, non-CKD patient. So bottom line, CKD should be observed as an independent risk factor for cardiovascular mortality. Again, al-a'mar biyadillah, but looking at epidemiological studies, we see that diabetes eats from expectancy of life. So in a sense, it shortens life expectancy. And when you add CKD to it, we are talking about almost 14 to 16 years less life in a patient with diabetes compared to someone who does not have diabetes or early CKD. Now, each one of them independently has that characteristic, so they are both risk factors. Now, here's where we say that risk factors for cardiovascular disease have been witnessed in the field of nephrology. As the estimated GFR declines to your right, you can see that on the x-axis, I have the GFR here. So as I drop below 90, below 60, I have an increase in the adjusted hazard ratio of cardiovascular mortality. The same is also seen when we have an increase in the urine albumin creatinine ratio. So, and when we hit the 30 milligrams per gram, this is where we can say that there is clearly a higher risk, talking about doubling, tripling, and even 4 times the hazard ratio for someone who had normal urine albumin creatinine ratio. So this is just to say, if you have albuminuria or if you have a declined GFR, these are additional cardiac risk factors. Now, in a patient with diabetes, we know that diabetes is a progressive disease. So as time goes by, we expect to develop complications. Now, earlier in the state of diagnosis, there may be almost 15 to 25% of patients who have albuminuria or a small degree of it. Now, as time goes by, this albuminuria is expected to increase along with worsening renal function based on estimated GFR. But usually the albuminuria is an earlier state before the decline of the estimated GFR. Therefore, relying on creatinine alone or the calculated estimated GFR alone is not enough. Both together comprise a better screening tool for early nephropathy. Now, our colleagues from nephrology have defined what is CKD, or chronic kidney disease. And in a patient with diabetes, we can call it diabetic kidney disease. So in the early stages, we just need 2 main modalities of diagnosis, a blood test and a urine test. And if you have either one of them, then we can confirm the presence of nephropathy. So the blood test is the creatinine, which you can calculate an estimated GFR. And if you don't have it in your lab, then you can actually go on to any of the nephrology societies and plug in the numbers based on either age or weight and the creatinine, and you can come up with an estimated GFR. The urine test is to screen for the urine albumin creatinine ratio, or a spot urine. We don't need any more 24-hour urine collections. And if you have a GFR that's below 60 mils per minute, or a urine albumin creatinine ratio that's above 30, that is persistent, which means you do it more than once. So not just once qualifies, you need to have it at least in 2 separate settings. So the persistent proteinuria, then you qualify for the diagnosis of CKD or DKD. And in a patient who has type 2 diabetes, it is standard of care to do this screening at least annually. And if you have it, if you have just mild albuminuria, then you should track it at least twice a year. Now, the importance of having albuminuria is that as albuminuria increases, the risk increases of cardiovascular disease. The same applies to having a decline in the GFR. So as we progress in declining GFR, we have a higher stage of kidney disease and kidney dysfunction, but also carries with it an increased risk of cardiovascular disease. Now, all of what I have said is a little underappreciated in the general population of physicians. Healthcare providers still do not appreciate that massive risk of having CKD in the presence of type 2 diabetes. We should all collectively start working on our colleagues and our patients to better educate them and try to find means of these education. So let me take you to the concept of progression of CKD and how it happens. Now, for many years, we have known that hemodynamic instability with having high blood pressure that pounds on the kidney will lead to kidney damage. Now, we also know that hyperglycemia with poor metabolic control, diabetes, abnormally high levels will also worsen kidney function. But there is an element of fibrosis and inflammation that we rarely talk about, which we have recently known, that ultimately will lead to progression of kidney disease. And we have tools to minimize the hemodynamic or elevated blood pressure, which is the antihypertensives. We have tools to control the blood sugar, but we haven't found tools to control the inflammation, because all of these collectively lead to tubular interstitial damage, glomerulosclerosis, mesangial expansion, which are the highlights of the histopathological abnormalities that take place in a kidney that is progressing with chronic kidney disease. So to halt that, we have learned that back in the early 2000s, losartan from the RENAL trial reduced the risk from those who are on placebo compared to those on losartan. We were able to reduce the risk by almost 16%. We still had a residual risk of kidney progression. These were patients who had albuminuria, and they looked at outcomes of doubling of serum creatinine, kidney failure. So we actually were able to minimize that risk. More recently, the DAPA-CKD, which is the dapagliflozin, the SGLT2 inhibitor, was able to minimize the risk in patients who had very high urine albumin creatinine ratio, albuminuria, type 2 diabetes, and even a subpopulation who are non-diabetic that looked into these outcomes of sustained eGFR decline or end-stage kidney disease or death from kidney disease. Now, again, here's where we address the hemodynamic instability or the abnormality. We address the metabolic with SGLT2 inhibitors and some studies with GLP-1 receptor agonist, the long-acting ones. But do we have something that addresses the inflammation? Well, now, after knowing and understanding that there is a receptor known as the mineralocorticoid receptor that when stimulated by aldosterone, by cortisol, by other mineralocorticoids, actually leads to a cascade of intracellular and extracellular worsening of the inflammatory burden within the cell, meaning that we have more reactive oxygen species, we have more pro-inflammatory cytokines floating, and ultimately this leads to the acceleration of fibrosis and inflammation within the kidney and even outside the kidney within the vascular endothelium as well as the myocardium. So these mineralocorticoid receptor activation is a bad thing. Someone thought, well, how about we block it? And this is where the molecule finerenone came, which was a selective non-steroidal mineralocorticoid receptor antagonist that blocks the activation of mineralocorticoid receptors. And when it does that selectively, it was shown to have a good benefit, as we'll see later on with Dr. Saeed's lecture, on the kidney, on the heart in patients with diabetes, mainly through reducing the oxidative stress, decreasing the fibrotic burden. So finally, as we said, we can address the inflammation and fibrosis. Again, this is a mineralocorticoid receptor antagonist. We will see the phase 3 trials that showed how this can protect it. Now, as an endocrinologist, we deal with hormones. Now, spironolactone is a non-selective and probably even a steroidal mineralocorticoid receptor antagonist. So what is the difference between finerenone and spironolactone? Well, one thing that we see with spironolactone that makes it very difficult to comply with in males specifically is sexual dysfunction, whether it's gynecomastia, now painful gynecomastia, mastodynia, as well as erectile dysfunction, and even the hyperkalemia from a metabolic perspective. It causes slightly more hyperkalemia compared to the selective mineralocorticoid receptor antagonists. So the phase 2 dose-finding trials started with this phase 2A known as the ARTS trial, where they used finerenone on patients with CKD and HFrEF, or heart failure with reduced ejection fraction, and they compared it to placebo. They also wanted to see the effect of potassium when we use finerenone versus placebo versus spironolactone. The phase 2B trials addressed the finerenone in patients with diabetic nephropathy, meaning they had albuminuria and type 2 diabetics, as well as heart failure and type 2 diabetes compared to eplerenone. Now, what did we find? Here are the highlights. That in the ARTS-DN, which is with diabetic retinopathy, we had a good reduction of urine albumin-creatinine ratio with any dose. The optimal dose was ultimately decided to be the 10 milligram, because you can reduce the urine albumin-creatinine ratio by 24%, and the high dose 20 milligram, which reduces it by almost 38%. Now, the good thing is that this happened with a very minimal change in systolic blood pressure. So it didn't create severe hypotension when we used the higher doses. It helped with reduction of blood pressure, but not to a degree that that caused any reduction or serious adverse events. In the sub-analysis looking into the effect of finerenone on potassium compared to spironolactone, you can see that there's a huge difference, much reduced hyperkalemia compared to spironolactone in patients with CKD and HFrEF. Again, with the ARTS-DN in diabetic nephropathy, you can see that very minimal increase. We're talking about 0.2, 0.3 millimoles of elevation of potassium, which was relatively negligible. So this tells us that this is probably a better, let's say, mineralocorticoid receptor blocker than spironolactone. And this was reflected ultimately in the guidelines, the diabetes guideline, our standard of care, which is published every year, starting from 2022. You can see that the ADA guidelines started to mention finerenone as in patients with CKD who are at increase of risk of cardiovascular events or CKD progression, and are unable to use an SGLT2 inhibitor, which we are all comfortable using, we should use and consider finerenone. And this is recommended to reduce the CKD progression and to reduce the cardiovascular events. Now, the data will be presented by Dr. Saeed Al-Ghamdi. Now, I just want to also reflect on the most recent standard of care that was just published 2 months ago from 2023. They also have a strong language in saying that patients with type 2 diabetes and CKD with albuminuria, after using the maximum tolerated ACE on ARBs, we should think of the addition of finerenone. Notice that they didn't mention the SGLT2 inhibitor. So it's independent of the SGLT2, the finerenone has that risk reduction. So I will stop here by concluding and saying, the burden of cardiovascular disease is substantially high, specifically in our patients with diabetes and CKD. Despite the existing treatments, we need more tools to reduce that risk. There is a new focus now in our management when we approach patients with type 2 diabetes involving the CKD and looking at the cardiovascular outcomes. So I'll stop here and thank you for your attention.
Thank you very much, Dr. Hussein. Very thorough highlight and understanding of the mechanism and the outcomes. And as you said, it's time to jump into the actual data and trials from Dr. Saeed Al-Ghamdi, who will take us through a practical look at cardiorenal protection for chronic kidney disease and type 2 diabetes. So please, Dr. Al-Ghamdi.
السلام عليكم ورحمة الله وبركاته. Do you see me?
Yeah. Can you share your screen?
Sitting, yeah. Yeah. Share my screen.
Yes. I'll make it slide view, please.
Do you see me or don't see me?
We see the screen. Yeah, very well. Go ahead, please. Thank you.
What about me?
We see you as well.
Right. Thank you very much. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. I start by thanking the Saudi Heart Association for the kind invitation, and I must thank my dear friend Hussein Badawi for his excellent review of the mechanism, and he linked very well the relation between the heart and the kidney in patients with diabetes, and he actually facilitated my presentation a great deal. So thank you, Hussein. I'll come from kidney specialist view. When we look at this is actually the most recent data regarding the global burden of kidney disease in the world, and they compared at 2 time frames of 10 years period between certain until 2008, from 1990 to 2016, and they looked at the change in the global burden of the CKD in the world. And what they found that most recently that we have increased by 89% of CKD in the world, with prevalence increased by 87%. Death rate also has increased, most likely due to the cardiovascular element that brings to us the relation between heart and the kidney, the cardiorenal protection and importance of this one. And the death rate increased by 98%, and also disability has increased by 63%. And most important culprit in the causation of this is diabetes, for sure. Ourselves, actually, we published this data in one of the prestigious journal, Kidney International Report, about the GCC countries, and actually published almost a year ago. And we looked at diabetes prevalence, treatment, control, and outcome among hemodialysis patients in the GCC region. And to the interest that we found that diabetic usually they have much higher mortality, which is the death rate about 15.6 compared to non-diabetic by 6.2 per 6.2 patients per 100 patients here. So mortality is really high, which underlies the importance of cardiac protection in even dialysis population. And this actually tells you how much we are. We're in Saudi Arabia, almost 45% of dialysis populations are diabetic, but in other GCC countries, much higher, reaching up to 74%. And we found that the mortality is much higher in patients with poor control of diabetes when the hemoglobin A1C exceed 9, and the best result you can get it when the hemoglobin A1C around 6 to 7. And this really has been shown by different adjustment of the factor which might play a part in the mortality, and found that the mortality rate is really increased up to 270 times in diabetic versus non-diabetic population. And we look at, I'll touch about the pathophysiology of diabetic kidney disease from nephrologist perspective. And really, as I said, thanks to Hussein. But this one is Fuad Ziada has summarized from France how diabetes is really producing its major catastrophe. Most important is the hyperglycemia. Hyperglycemia can increase the TGF beta, which is responsible for kidney fibrosis, which is the sugar factor beta, which is responsible for fibrosis. And this really factor has been known for a long time. That's why actually what we have with diabetes, when you look at the biopsy, we find actually either nodular or diffuse sclerosis, either in the interstitium or in the glomeruli. So this suggests that hyperglycemia is part one, but also hypertension and angiotensin too, it's really playing a part. And also there is some cytokines plays a part, like VEGF and hypertension. All actually will lead to renal fibrosis and renal sclerosis. And when I look at this one, it looks about hyperglycemia as a domain, looks at hypertension or interglomerular pressure as a domain, and it looks at fibrosis, the third domain, which I'll discuss in more details. These are the target of 3 domains of diabetic nephropathy, which we want to treat it. The first one is the metabolic domain, and that's why right now we have some good drugs which really control the diabetes much better than what we had in the past, and probably we will take care of this domain. Hemodynamic domain, I'm sure that we are working on it over 3 decades, especially with the use of ACE and ARB. And most recently, we had SGLT2 inhibitor, which really actually works through decreasing intraglomerular pressure. And the most interestingly, the third domain, which has been left for quite some time unattended, and we are fortunate enough to have medication which really targets this part, which is called finerenone, which MRA antagonist, mineral corticoid receptor antagonist. As we know that diabetes, it takes 15 to 20 years to produce its second type 1, but it's really more than 5 years, but it's really it requires some time, and usually associated with neuropathy in about 2/3 of the cases, proteinuria in most of the cases, and 50% will progress to end-stage disease. And the majority of the patients, they actually, many of those patients, they die before reaching end-stage renal disease. And when you look at the normal glomerular, you have the afferent arterial, efferent arterial, and the intraglomerular pressure is normal in normal individual. But diabetic, no, you have actually due to hyperglycemia, afferent arteriolar vasodilatation, and also efferent arterial vasoconstriction, and both actually. But when you constrict the outgoing and increase the incoming, you will increase the intraglomerular pressure and increase hyperfiltration. And this is actually the hemodynamic theory. That's why we really celebrated the arrival of ACE receptor more than 3 decades ago, but unfortunately don't do significant work, and still we have increasing incidence and prevalence of diabetes and diabetic kidney disease. And despite that, we targeted the efferent arterial vasoconstriction by giving ACE and ARB, and most recently we targeted the afferent arteriolar through the SGLT, but still we do have a problem. And we have to remind you and remind myself that the progression of kidney disease is not in all patients' population. There is different trajectories. There is some sort of small group of patients that did not progress, but the majority do progress at different rhythm and pace. But certainly there is some genetic factors which play a significant part in the causation and the progression of CKD. But what has been found in all of this study that actually hypertension and intraglomerular pressure probably plays a major role. So what management do we have? We have management, we have strategy to prevent attenuation diabetic kidney disease, which is diabetic control, optimal blood pressure control, use of ACE or ARB, treatment of hyperlipidemia, weight reduction, use of SGLT2 inhibitor, GLP-A, which really is really also an excellent add-on, and most recently the MRA. If you look at the metabolic dopamine, which really brings you the control of blood sugar, and this has been known for more than 3 decades. When Ed Lewis and other colleagues in DCCT study, they published their study in 1993 in the New England Journal of Medicine, and they found very clearly that whenever you have intensive control of diabetes to the extent of hemoglobin A1C 7.3, that you reduce the microvascular complications, especially nephropathy, by 54% compared to placebo. And they have found actually in some other post-hoc analysis that when you do this one, actually this is that the higher the hemoglobin A1C, the more nephropathy, neuropathy, and microalbuminuria. So suggest that probably we have to keep our hemoglobin A1C around 7 in order to prevent these microvascular complications. Komomato did the same and found exactly similar result of Ed Lewis and his colleague in DCCT studies. And also UKPDS study from UK showed exactly the same thing. And you could see in this slide that there is a reduction in microalbuminuria by 33% in patients who had intensive glycemic control of blood sugar. So this is the hemodynamic. We finished the metabolic theory. We go, or the metabolic domain. We go to the hemodynamic domain. And optimal blood pressure control by lowering intraglomerular pressure is really essential. And the first one to show it in an ASK study that showed a 38% reduction of GFR decline in stage of death due to when you use ACE inhibitor compared to amyloid calcium channel blockers or beta blocker. And whether you have normal GFR or abnormal GFR, the outcome is probably the same. And most importantly, they found that actually it's not just only this ACE or ARB, but actually the mere control of blood pressure is really quite essential in order to prevent the vascular complication, including the heart, cardiac, and renal complications. There is actually plethora of ACE and ARB medication over the last 3 decades, and most 2 decades of the ACE and ARB. where we have several studies, which you know whatever of them. And actually, I'll touch on one of the very important study which has been published from, I think, Denmark at that time, which is the ARB studies which using the irbesartan and what you call the ERMA2 study, found that you give 300 milligrams of irbesartan, you have 70% reduction of patients going from microalbuminuria to overt nephropathy or overt proteinuria, which suggests that probably using of this ARB, like irbesartan full dose, it has significant effect compared with if you're using 150 milligram. Also, the same time frame, we have renal study which uses losartan, which has shown by Dr. Hussein, which showed that almost 60% reduction of primary outcome, composite outcome, which include many things, including renal and others, and mortality also. And they found that only 60% risk reduction by using losartan, and also IDENT2, which is used irbesartan for patients who had established chronic kidney disease or diabetic kidney disease, and they found that by using irbesartan, you have significant risk reduction of primary composite outcome. But unfortunately, experience and literature has shown us that unfortunately we do have, whenever you use ACE or ARB, we have the problem with hyperkalemia, and only 50% or less than 50% of our patients, they are receiving the maximum dose of ACE or ARB due to the hyperkalemia. And this is really a major problem, and I brought it here just to think that probably we are not getting enough from ACE and ARB because we are not using the maximum tolerated dose. Most of the cases are either stopped or reduced dose in order to avoid hyperkalemia. And various studies showing up to 16 to 20% of patients who are ACE or ARB, they have hyperkalemia. Also, not to mention spironolactone, they have actually spironolactone epiluronone, which is the non-selective one. They have actually more tendency to cause hyperkalemia. We are fortunate, as I said, enough that to have a SGLT over the last 5 or 6 years, and we found that SGLT works in 2 domains, works in metabolic domain and also in hemodynamic domain. If you look at the RAS here, it blocks the efferent arteriole. It's dilate the efferent arterioles in order to cause vasodilatation and hence reducing interglomerular pressure. But now we have actually the SGLT2 inhibition by vasoconstricting the afferent here to cause vasoconstriction and hence reducing interglomerular pressure. So we have 2 drugs, one vasoconstrict the afferent, one vasodilate the efferent, and hence both actually work together to reduce the interglomerular pressure. Of course, you are aware of many of the studies which has been published over the last 6 years, including the EMBARIG study, outcome study, which would reduce both the renal and cardiac outcome by almost equivalent percentage. If you look at the cardiovascular death by 38% and also for renal outcome by 39%, which suggests that heart and the kidney, most of the medication we're using right now is used to protect both organs. And this showing the primary outcome, which really compared to placebo very significantly, and also the death from any cause, cardiovascular death from cardiovascular events, hospitalization due to heart failure, all reduced by empagliflozin. The EMBA outcome or EMBARIG outcome, which has done, and we showed that actually if you use the empagliflozin will lead to actually flattening of the curve compared to placebo when the GFR continue to decline compared to placebo. And this slide showing that the analysis of the EMBARIG outcome studies, which use SGLT2 inhibitor, actually which to reduce afferent arterial vasoconstriction and has decreased interglomerular pressure and albuminuria. They use actually more than 7,000 patients, and the primary outcome was decreased cardiovascular risk and a second outcome renal. And what they found that actually all of it, that this flat curve, which has been reduced by, so there is no worsening of renal function after 3.2 years in patients who received empagliflozin compared to placebo, that continued for that particular time. But this one, irrespective of medication was taken by the patient, whether the patient was an ACE or ARB or on diuretics or calcium channel blocker, or even on NSAID. So these suggested that empagliflozin has a greater protective effects independent of medication and other factors. Of course, dapagliflozin came, which showed similar result to EMBA, almost 61% of the renal outcome, and also combined to renal and cardiac outcome, and also about 0.7%, which is about 29% in the cardiac outcome. So both really, which is SGLT, works in both in the heart and on the kidney. And here you could see, for example, the primary composite outcome, dapagliflozin is really quite superior, and we look at the renal specific is really quite clear, and also for cardiac specific. This DAPA-CKD trial, I must tell you, just to prove that the issue is really interglomerular pressure, I brought this study in Kidney International, where they use in DAPA-CKD at least 161 patients who have IgA nephropathy but have no diabetes. And they found that significant reduction of progression with dapagliflozin compared to placebo, which suggests that the theory here, or the domain, is the hemodynamic domain or intraglomerular pressure, which has been reduced by dapagliflozin irrespective to the metabolic domain. GLP, of course, GLP-A is really dulaglutide, which really has been shown in 2 doses, 0.75 and 1.5 was the full dose. The full dose really have more effect compared to placebo and risk reduction of the renal outcome. Now we come to the most important part, which is the subject of our discussion today, which has been discussed with Dr. Hussein, which is the inflammatory and fibrotic domain, and which is the use of mineralocorticoid receptor antagonists, which has been discussed this slide by Hussein. As you could see that the genetic transcription by using mineralocorticoid, by the mineralocorticoid receptor here, will lead to inflammation and fibrosis. But when you use Regeneron, block this one, and here therefore you will prevent the inflammation and fibrosis. And that's actually the major idea behind the study, which we'll discuss, the phase 3 trials about using Fidelio and Figaro, and the pooled data of fidelity studies. And if you look at the Fidelio DKD rationale, that we found the same, which I discussed by Hussein also, that if you look at losartan, only reduce the risk reduction about 60%, leaving a huge residual risk not tackled, and what you call huge unmet need in trying to reduce this. Unfortunately, that we have with the ACE, we have right now the SGLT2, which has reduced, narrowing the residual risk, leaving a place. So here we have tackled the hemodynamic theory, we tackled the metabolic theory, and both of them has led to almost 50-60% risk reduction, but leaving almost significant reduction, or at least 20% to the not touched. And here comes actually that tackling of the inflammation and fibrosis, and as I said, is not significantly touched by previous. And this brings us to Fidelio study, Fidelio DKD study, where they have actually at least around 6,000 patients. They are dividing into them to that type 2 diabetes to 2 groups: on placebo 2,841 patients, and Regeneron group, which is 2,833 patients. And they list the placebo who did not receive Regeneron, here the Regeneron group, and they used it for a significant period of time. And they looked actually that here, that primary outcome was reduced by 80% in the Regeneron group. So hazard ratio was 0.82 compared to the reference, which is 1 here. And the cardiac secondary, because the primary outcome is really renal, kidney disease, sustained decrease of GFR more than 40%, death from renal causes. Secondary outcome is mostly cardiovascular outcome, like cardiovascular death, then fatal MI, and hospitalization due to heart failure. And they found actually there is risk reduction of both the primary and secondary outcome. And if you look at, most importantly here, that proteinuria has been reduced by 31% in patients who received Regeneron compared to placebo. And as has been mentioned before, that blood pressure, systolic blood pressure, was not changed due to the effect of Regeneron and both group and the Regeneron group, or minimally change, which is about 2 millimeter, which is nothing actually can there. So it's not statistically significant. So here you have a drug which does not drop blood pressure, has nothing to do with the blood pressure, and also does not affect the metabolic domain. where hemoglobin A1C is really constant in both placebo and the treatment group. The most here the serum potassium. Of course, serum potassium has increased from and the difference between the Fenderon group to placebo group is by 0.2, from 4.4 to 4.6. So there is minimal increase in serum potassium, and we'll discuss it at later stage here. But certainly, there's only 0.2 increase, mean increase of serum potassium in the treatment group compared to placebo group. This, we go back to Fidelio study again. We found that if we look at the primary outcome, which is the kidney failure, sustained more than 40% decrease in GFR from baseline, or renal death. And we found that by using Fenderon, you have 18% risk reduction, which really narrows significantly the gap or the residual risk in patients with DKD. And whatever you take at the primary, take about kidney failure, take an stage disease, sustained GFR reduction, whatever you take, renal death, especially these are 4 domain, you find that all in favor of Fenderon when you compare to placebo on the right side. So what about the secondary endpoint, which is really cardiovascular endpoint, which is cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization due to heart failure? It has been reduced in Fenderon group compared to placebo by 14%. This will bring us to this. We have very efficacious treatment, and the most interesting here that the number needed to treat, and which number to treat for Fenderon was actually for primary kidney endpoints is 29, which is really quite low compared to major other studies. So this is really a very efficacious drug if you calculate the number needed to treat. And also for secondary cardiovascular endpoints, about 42. So the Fenderon Fidelio, which is discussed right now, is almost close to 6,000 patients. And then after the study started 14th of April 2020, Figaro, which really more of cardiovascular endpoints as a primary outcome, and secondary outcome is renal. While Fidelio, primary outcome is renal, and secondary outcome, which I discussed earlier on, is the cardiovascular, which showed reduction of both, of course, more the kidney than the cardiovascular. But we look into Figaro, which will about 7,436 patients, started February 2nd, 2022, and published in last year, actually, in January by Bacchus. If you look at Fidelio study, of Figaro, actually more interesting here, Figaro, that they have significant number of patients, 314 in the Fenderon group compared to placebo. They are on SGLT2, and also there is 308 patients, they are on GLP-A, and very significant number of patients, more than 3,680, and similar that to the placebo, they are on RAS inhibition. So it suggests that this drug can be used in patients that are on RAS, on AS or ARB, in patients that are on diuretic, patients on statin, and also in patients who are having other glucose lowering like GLP-A or SGLT2 inhibitors. If you look at the figure, which really the primary outcome is the time to cardiovascular death, then fatal MI, then fatal stroke or hospitalization for heart failure, and they found there is about a reduction, about almost 40% of reduction of composite primary outcome in Fenderon group compared to placebo group. And when you look at actually, if you look at the secondary outcome, it really looks mostly as renal outcome, and also showed risk reduction by almost 12.7% for this one. So actually, both Fidelity, which really target, Fidelity, the target showed reduction significantly for primary kidney outcome, and secondary kidney outcome is also for Figaro. And no matter whatever you take, whether composite cardiovascular outcome for Fidelity or heart failure, hospitalization for heart failure, or cardiovascular death or other, you find all in favor of Fenderon. And similar for Fidelity, which is morely as renal specific and secondary as cardiovascular, has the same thing, same outcome. You see it here regarding the GFR reduction, kidney failure, and stage disease, all in favor and favor of Fenderon. So these are actually the both study, which is Fidelity, renal specific and secondary as cardiovascular, or Figaro, which is a cardiovascular and secondary as renal specific. Both showed the quite positive effects and risk reduction in both groups. But we come here right now to the safety, which has been discussed by my colleague Hussein, showing that systemic blood pressure is not affected, and there is no sexual side effect, especially gynecomastia here. And the increased hyperkalemia was there. Honestly, we cannot actually say it's not there, and we have to be careful about it. But if you look at this one, is only 0.2 risk reduction. So here I must come to a conclusion saying that the three domain of diabetic nephropathy has to be tackled collectively in order to reduce that huge global burden of CKD or diabetic kidney disease. And more is not just touching about metabolic how to control it. I'm sure that we have the endocrinologist is doing really an excellent job here by adequate blood sugar control and using a variety of things, either many variety of insulin, GLP-A, or even the SGLT2, which requires probably a cornerstone of management in these days. Regarding the hemodynamic theory, which is discussed, which reduce intraglomerular pressure, either you control by blood pressure by using antihypertensive, whatever the antihypertensive, or using ACE or ARB to reduce intraglomerular pressure, or using SGLT2 inhibitors, which really a major one, which is also works in the hemodynamic domain, which I proved that one to you. And the third one, which is really the most recent domain, which we brought us some hope that we one day we will be able to fight this pandemic of CKD and cardiac disease in patients with type 2 diabetes. We have the phenylneuron, which have proved that really reduce the outcome significantly in favor of the treatment group. And I'm sure that really by we have started just using this medication, and probably I'll come in the case discussing a few cases regarding how to tackle this disease. And this will bring us to end. I really thank you very much for giving me this opportunity to show you what I have in mind. Thank you.
Thank you very much, Dr. Saeed, for this thorough discussion and explanation. For the sake of time, we'll keep on moving. I would like to remind our audience that if you would like to submit any questions, please do through the Q&A link, and the discussion part, we will discuss them all, inshallah. For now, we'll move on to a multidisciplinary approach in managing diabetic kidney disease through case scenarios, where Dr. Hussein and Dr. Saeed will each present a case and see the practical approach for these patients. So please, Dr. Hussein, if you don't mind starting.
Okay. Thank you, Dr. Saeed, for really making things very clear. Even I, as an endocrinologist, have learned a lot of details that will benefit my patients, inshallah. So the task I have at hand now is to try to implement what we have just learned from the previous two talks and applying it to the next patient we see who fits the criteria we spoke about. And I brought actually my first patient who got this medication. So to begin with, this is Mr. Samir. He's an engineer, 46-year-old with type 2 diabetes for more than 6 years. Now, unfortunately, upon diagnosis of type 2 diabetes, he was found to have an element of chronic kidney disease based on a reduced estimated GFR, which was 55 mils per minute. Now, when he was referred to me, he was referred to improve his glycemic control. And his A1C at the time of presentation to me was 7.5. So suboptimally controlled for a young patient like him. Ideally, we'd like to bring him below 7%. He is slightly overweight, BMI of 28. His estimated GFR upon testing was 42 mils per minute. So it even worsened from his baseline, so making him a stage 3B. His potassium at the time was 4.2, and he had some albuminuria. He didn't have any signs of symptomatic heart failure. He was well covered with a statin and achieving an LDL that is below 70 milligrams, which is 50 milligrams per deciliter. And he was titrated up on his ARBs to the maximum, which was 300 milligrams per day. So he came with the anti-diabetic regimen being metformin, 500 milligrams twice a day, and a weekly dulaglutide as a weekly injection. So part of what we found is on further follow-up, he presented with worsening albuminuria. So this is also a danger sign, moving from minimally elevated to severely elevated albuminuria. This is a sign of kidney progression. So the next question comes as, how should we approach Mr. Samir? Now, what I have at hand is suboptimally controlled blood sugar. We can argue that blood pressure is almost at goal based on whatever guideline you may prefer. Ideally, he'd be below 135 at home, but in the office below 140, so he's acceptable. But we have this nephropathy that's worsening. So what would be our recommendation? Now, as a diabetologist or an endocrinologist or an internist, I would first look at what we have learned from the studies. A patient like him with CKD and type 2, I would try to fix the hemodynamic instability. And of course, I showed you he's on irbesartan, as we've seen with Dr. Saeed from the IDNT. You can actually have a reduced progression of disease. Yet, despite that, the residual risk remains. Therefore, we should intervene with another modality. So his blood sugar is uncontrolled, and we chose to give him dapagliflozin because, as we've seen, it is a good anti-diabetic agent, or let's say it can fix his blood sugar and even reduce the risk of kidney progression. So what we like to show our patients now is this heat map from CKD. And we tell the patients, well, you know, this is where you fall into. This red zone is high risk. So it's another way to engage your patient and empower them with knowledge so they appreciate and they can take part in the decision-making when you tell them, well, I want to give you an extra medication to help reduce this risk that you already fallen into. Why is he here? Because he is at increased albuminuria as well as stage 3B for the CKD. Now, again, this is him. And after adding dapagliflozin as an anti-diabetic medication to his current regimen, mashallah, his A1C got much better, down to goal, which is 6.8. His blood pressure actually improved, and this is something we see when we add SGLT2 inhibitors. And the great element we have seen is that there was an improvement in the urine albumin-creatinine ratio, dropping almost by 50% from 1,300 to 700. Now, something we might see when we add SGLT2 is the same thing we might see when we add an ACE or an ARB, which is the reduction in GFR. So his baseline was 42. After initiating DAPA, he's at 40. This still does not limit us from continuing it. So we kept him on. Now, the question is, are we happy with this 700 milligram per gram of urine albumin-creatinine ratio? Is there something else we can do apart from fixing the hemodynamic and metabolic parameter? So this is where I'll pose the question to you all. And I think we have learned today that we have an additional tool. And this tool will be the finerenone. So we have learned from the phase 3 trials that finerenone added can actually reduce the urine albumin-creatinine ratio by almost 30–40%, which is persistent. And this is shown very early, within the first quarter of the year, first 3 to 4 months, and without compromising A1C, without even causing any abnormalities in the blood pressure. So upon initiating finerenone, and as we have learned, we start with a 10 milligram dosage, we actually had further improvement of his previous elevated urine albumin-creatinine ratio. So you can see now it came down all the way to 200, starting off from 1,300 on ARBs, came down to 700 with the SGLT2 inhibitors, and now with the finerenone, we dropped it down from 400 to 200. What was reassuring is that the potassium, which you should monitor in a patient who you initiate finerenone, and at least once a year after stability, is that it increased by almost 2 or 2/10 or 0.2. So he was at 4.2, went up to 4.4, 4.6 is where he stabilized, which is not hyperkalemia and is reassuring. His eGFR is still where he is. So at this point, we were able to give him all the tools we have to offer to reduce and minimize cardiovascular risk, giving him the SGLT2 inhibitors, the ARBs, and the non-selective, non-steroidal mineralocorticoid receptor antagonists. Now, the question you will be faced with, okay, well, we had some good response, and now that I have 210, can I bring it down to 30 when I increase the dose? Well, the recommendation with this label on the drug is if you are at GFR that's below 60, just maintain 10. So 10 milligram is enough for him. And that is what we kept him on. So I hope this was beneficial for you all. Thank you.
Thank you very much, Dr. Hussain. This was very interesting. Now, I'm very happy to see someone at a very good target of LDL, which we don't see that much, although the dose was not big. It's just on a TORVA 10, but it's nice to stress on the importance of having these patients on a good target LDL, generally if they are only diabetic less than 100, but if they have other risks. Now, the other thing I would have loved to see if he was screened for any further cardiovascular risks or having any cardiovascular disease, knowing that urine albumin creatinine ratio is a high indicator of cardiovascular disease, whether he had any stress test or probably calcium score or ECG and echo, and just to identify, does he have, and retinopathy, for example. I'm pretty sure all these were part of the holistic management of the patient.
We'll make sure to add all these details in the next
Can't hear
presentation,
you.
inshallah.
Yeah.
I was saying we'll make sure to add the rest of the cardiovascular risk assessment in the next presentation, inshallah.
Excellent, excellent. Thank you very much. So the next case will be with Dr. Saeed. If you don't mind going ahead, please.
Assalamu alaikum. No, this is not the one. Yeah, here. Okay. Hi. Thank you very much, and we'll come back, and I'll present one case, which I also can do two, but I'll do one case right now, who's a patient seen a 67-year-old male who's type 2 diabetes for 25 years, history of ischemic heart disease and PCI deployment. And his serum creatinine, when he came for the first time, he knew about it. It was about a week or two before he comes to see me. Was his serum creatinine 1.7 milligram deciliter. Was 3 months before he see me, actually. Potassium was 4.8. Hemoglobin C was very high. It's not really controlled. And he said that all the time, postprandial blood sugar is more than 300. They had mild lower limb edema, mild to moderate. The clinical, when I examined his euvolemic, he was taking actually Lantus, Novorapid, semaglutide oral, valsartan, atorvastatin, and his fasting blood sugar has been 200, postprandial 321. So what's your choice to control his blood sugar? Whether go diet, increase insulin dose, SGLT2 inhibitors, or other inhibitors, but and I decided at that time, of course, to get some restriction about dietary control, some added SGLT2 inhibitors, dapagliflozin more precisely, and I increase the insulin whenever actually blood sugar is really postprandial is not really controlled, or the fasting one by Lantus. And we found that at that time we made sure that he had the most thing. He is having actually lower lymphedema. His lower lymphedema mostly due to the proteinuria. He's having actually 3 to 4 plus protein in the urine, but he did not do the albumin creatinine ratio. But I'm assuming that with his serum albumin is always 31-30, suggesting that he has significant proteinuria. That time we said, well, probably we have to increase, so add a diet, dapagliflozin, continue other medication, and after adding dapagliflozin, his fasting blood sugar becomes really fantastic. 88, post-Bradley was 65. So we decided that probably we are winning with his diabetes control, with overall control, but what else could be done? Could we add Fenderon in this elderly male patient, 6'7", who had all the cardiovascular risk factor? He had hyperlipidemia for a long time, diabetes for a long time, hypertension, and he also has been suffering in the past from ischemic heart disease. He had angina, and he had, as I said, 4 Fistul's disease, where he had actually deployment of stent, and 3 of them. So that time we knew that we are dealing with patients with high risk of cardiovascular disease and also high risk of renal progression. So we decided to add Fenderon 10 milligram once daily. And when I added Fenderon, I kept watching him. His creatinine did not change, 1.72. Blood pressure is the same, not changed. And his potassium was 4.8 pre-treatment, and almost a month after, 4.9. So I was really quite relaxed and satisfied. Of course, you will not show, I didn't show the proteinuria effect by using Fenderon. I'm sure it's rather reduced, but I'm dealing with somebody who's really, you could see from his long-standing history of hyperglycemia, not ever control blood sugar, that how much he is really compliant with investigation other. But at least I made sure that family member will do for him the creatinine and potassium in order to make sure that he's in safe ground. And that's the case, which really, actually it's my first case for using Fenderon. I have another 2 experience with Fenderon, but I don't think that we have time to discuss them unless people they want it. But certainly, it's gave me confidence after the 3 cases that Fenderon can be used, especially for high-risk cardiovascular and renal outcome group. The second case, which I had, is a patient who was actually had what you call strong family history of diabetic kidney disease. 3 other members of his family, they have been on dialysis, and the rapid progression of CKD. And they have, I mean, fortunately, he came early in the disease, where GFR almost 45 to 50. Early, it says not the same like his brother and sister, where they showed up to dialysis. But that case actually has been started on Fenderon. But I have one glitch there. I'm sure people, they will not agree with me. The patient had borderline hyperkalemia, and I decided just to give some potassium binders, because I thought this patient is really a high risk of disease progression, because you have all the cardiovascular, they have the renal negative outcome, and also have the proteinuria and other things, and probably Fenderon can be of value. So I agree with Hussein that Fenderon 10 milligram should be used at this GFR, should not be increased, and I think just potassium has to be watched 1 month post-treatment, at least, if not earlier. And if that's okay, then every 3 months, and you can continue carry on after that. And from what I've seen, the 3 cases, probably we are dealing a relatively safe drug. And some of our fear about using the drug has started to come less and less. And I'm sure that future will give us more experience. We can show it to you at one particular stage some time later. Thank you very much for giving me the support.
Thank you, Dr. Saeed. Again, may I ask, in this patient you just presented, what was the ejection fraction, knowing that he's ischemic heart disease and CABG, if he had any heart failure?
Well, I'll tell you something. This is a very good question, but honestly, I don't know the ejection fraction for one reason. The guy, he had an appointment with cardiologist 3-4, did not show up for that appointment. Yeah. And the second thing, that when I examine him clinically, when I really trust my clinical judgment from the clinical ground, that he has it's completely volemic. I know that he had lower lymphedema in the foot, but this can be explained to some extent with the nephrotic range proteinuria.
Well, I definitely trust your clinical judgment, but as you know, the same way we base now our management of, let's say, renal disease on numbers and urine album creatinine ratio, we like to base our heart failure management on the ejection fraction and the pro-BNP natriuretic peptides. The reason I'm saying is, of course, as you mentioned, non-compliance is a huge issue in our community, non-compliance with medications, non-compliance with follow-ups, which really impairs many of the benefits that we can see in these patients. But the reason I'm mentioning is that ARNIs, sacubitril/valsartan, has shown to improve kidney function as well on the long run in patients with low ejection fraction. Is he on an ARB or an ACE inhibitor? I didn't notice.
Yes, he has. He's on valsartan.
Valsartan, yes. So valsartan, sacubitril/valsartan, which is the ARNI, Entresto, probably, as many people know, has extra benefit on the in patients with reduced ejection fraction, and will improve the kidney function as well. So I think, although it's probably not the scope of our talk today, but just to let people know that our patients are holistic management. The same way we look at their diabetes, we look at their kidney disease, we're going to look at their heart, we're going to look at their nerves, we're going to look at their eyes, and a multidisciplinary approach to get the best benefits for our patients is actually recommended. In many centers, this is a one-stop shop where the patient sees the nephrologist and the endocrinologist and the cardiologist, and probably a diabetic foot manager, and you're all at the same setting or the same day, eases the visits and manages it all together. So again, I thank you both, and I think you raised an important point. I would like to hear both of your important of your experience and recommendation. If you really have such a patient who has higher potassium and you want to optimize these medications, would you use there are lots of data on using our potassium binders right now, whether they're the sodium or calcium based, and it helps us optimize our guideline directed therapies in these patients. So what's your experience and recommendations in such a case?
Said with me.
I'll start with you, Dr. Said.
Okay. Well, regarding I have a very good experience with the potassium binders. We are lucky enough to have two new medication. One of them called Batiromir, which is Veltasa, and the second one is the Lokelma, which is the zirconium trisilicate, and actually sodium zirconium. And both agents can be used. Unfortunately, the only prohibitive thing is the cost, because cost almost 1,300 riyals, 1,300 riyals for per month supply. And fortunately, that we have in the private practice, like what I'm doing right now, it's really covered by insurance. That's why the last patient which I reported, the one who had high risk of everything, his potassium is 5.2, but I didn't feel brave enough leaving him without some sort of the potassium binder. So I started with Batiromir or Veltasa, even one session every other day. But because I know that Federer is really here essential for him due to the risk of progression. He had heart family risk, history of disease progression, and other factors, which led me to use this one. I'm not advising people to go to use Federer with this one, because the cost is really quite prohibitive. And I think you have to think about your patients and the cost very vigilantly. But if you see some group with very high risk, I think it's really might have some justification, although there is no study supporting using this one in this setting of Federer.
Thank you. I think my biggest limitation is the mode of giving a sacket every day with the water, convincing patients to take the form rather than just a pill is a little difficult, but price is an issue as well. Dr. Hussein, my question to you is, now when you have such a patient like the one you presented, and you have urine albumin creatinine raised, would you started with dapagliflozin first and then added finerenone. Would you would you change the order, knowing more about finerenone, or would you use them both at the same time together, or would you still stick with the same? Is it just because we know more about SGLT2 inhibitors? How would this guide you in your management?
I think that's an important, let's say, unanswered question in the field of scientific data. Is sequential therapy versus simultaneous introduction. I'll just tell you, for this particular patient, presenting before we actually had finerenone at hand is what dictated having the SGLT2 introduction. At the same time, as I mentioned, he was suboptimally controlled from a diabetes perspective. So definitely, if I had the finerenone, possibly I would have even placed or given him both at once. One thing I was just going to step back and answer the question you addressed with Dr. Saeed with regards to hyperkalemia. Now, our population are very fond of potassium-rich foods. So it's something that we sometimes forget to talk about or rely on the dietitian. But I think when introducing this drug, it's a good opportunity to just remind them about that. And the second thing with regards to the fear of hyperkalemia, I think when we look at the sub-analysis of those who were on SGLT2, the SGLT2 inhibitors kind of mitigated that hyperkalemic side effect. So if I had this patient, probably I would have given him both at once. Of course, after discussing with the patient. So if he said, no, I don't want to take lots of pills or what so, and I have, a patient discussion, but he was willing to take them both, I probably would have given both at once. You can do either or. So if I present him as a patient who came with good control of diabetes, will I select the SGLT2 or the finerenone? Here, I can tell you the updated guidelines from the ADA. They didn't even mention that you had to have the SGLT2 as a stepwise approach. You can actually go in because I want to minimize the cardiac risk. So I hope that covers.
I think we as cardiologists have been a little bit more brave with hyperkalemia. In the past, we used to fear if the patient reached 5 or 5.1, especially with other mineralocorticoid antagonists. Now with the new data, we are comfortably going up to 5.4. And we actually found that one of the benefits of these drugs is preventing hypokalemia, which is risky, especially in heart failure patients. So up to 5.4 in our cardiac community, we're comfortable not jumping on or doing anything else. Now, one important point you mentioned, Dr. Hussain, right now is the guidelines. I personally have a passion towards guidelines. Alhamdulillah, Saudi Heart Association has developed several local guidelines, including heart failure, hypertension, and coronary syndromes. But what do you think, first of all, the impact, the updated guidelines you said on the use of or the more widespread use of these medications, and do you think adopting it in local guidelines will help also distribute the use in our local community?
Yeah, so I think having all of us here on this virtual table, as you mentioned, definitely increases the confidence of addressing diseases that we were not probably comfortable dealing with in the past. I can tell you, as an endocrinologist in the past, I definitely would have sent the patient very early on with very minimal albuminuria to my colleagues in nephrology, and probably they were overwhelmed with such patients. Now, with such interventions, I probably still claim ownership of the patient and feel that I am more confident in dealing with these complications. The same applies to heart failure. I think we're addressing heart failure at earlier stages, screening with BNP, and offering the SGLT2 inhibitors, even if they're on diuretics. So I think we've learned a lot from you in cardiology, as well as gained more experience from nephrology. Adopting the guys, I think as we get this comfort, we will be able to have these at primary care settings, because that is where the earlier intervention may have a bigger impact long term. So.
Now, to Dr. Saeed, and I think I'm answering this, the part of this question that came in, and what we saw when Dr. Hussein started the SGLT2 inhibitors. In many instances, when we start SGLT2 inhibitors, or patient is on ACE or ARB, and kidney function worsens a little bit, many of us just freak out and stop the medication immediately. How would you recommend as a nephrologist to deal with this, and when to say that's it, I have to stop, or how practically would you approach such a patient?
Well, thank you very much for this very important question. And I think the most important, when you look at the increase of serum creatinine, is the pattern of the increased creatinine. It's not just one particular reading. For example, if you are 170 and you rose to 185, 190, check another one a while later. And if you see, for example, it's going to 230, then you know that you are having a pattern of progression, and then you might stop this one. Most of the 30 talk about if it increased by 10%, don't worry about the continue, whether you're dealing by SGLT or dealing with S or R. And for me, as I said, what the most important issue is the pattern, and if there is a rapid increase, continuous increase, that really makes me stop the medication rather than just 20% increase of serum creatinine, because that's in the beginning. Actually, what they found, for example, most of, if you look at most studies, whether EMBARIG, we talk about the dapagliflozin studies or canagliflozin study, all of them, they have initial increase of serum creatinine in the beginning, but they come down with time. Similarly for ACE and R, except stage 5 or 4, 5 CKD, where we don't encourage using ACE or R, except when there is actually cardiac need for it, not for renal. So it's good, but for cardiac, for renal cause, probably it's too late to do anything at stage 5 CKD. Thank you.
Now, another question for you. In use of finerenone, do you, in a patient with diabetic kidney disease, would you wait until you see a high urine albumin creatinine ratio? Is there a cutoff that you would start at, or could you start it early on in any diabetic patient to prevent? When would you start?
Well, as you know, Dr. Walid, that what really we are evidence-based. We just go by evidence. Certainly, I have to have some proteinuria before I start the finerenone. And in the best case scenario, if you are in this sphere, for example, like when you're King Faisal, I do frequently albumin creatinine ratio. I'll do whatever, and like that's what you said. For example, the echocardiogram, we do it routinely for all of our patients, especially for the one who approach dialysis. So you all the time check as baseline the urine albumin creatinine ratio and follow it. But if the patient has no creatinine, no what you call no albuminuria, completely nothing, which you could see sometime in DKD, that requires actually other specified trials to answer this question.
Do you continue the medication while on dialysis?
Dialysis? No. For finerenone? No,
Yes.
No.
So once the patient approaches dialysis, you would stop it?
Well, because as I said, we are just beginning. If you look at, for example, January 2022, we had the paper of Becker's has been published.
Yeah.
I'm sure in the next 1 or 2 years, you'll have more and more studies targeting some particular question which you asked right now.
Yeah, I think it will have more effects, and probably, as we've seen in patients, maybe in heart failure, there are other mineralocorticoid antagonists in heart failure. So I guess a question that both of you touched
Let me ask
on.
you one question.
Yes.
One question. Touching about heart failure with mineralocorticoid.
Yes.
From data, do you have any evidence that, for example, which better for you, using the non-specific or specific MRA?
So a question that came here now, just answer the first question about ACE inhibitors and ARBs in diabetes and heart failure. As I said, there is now the ARNI category, or a classification of drugs, which is only one for now, sacubitril valsartan, and they are the best in heart failure. And if a patient is on ACE or ARB and developed heart failure, they should be switched to ARNI. And we should not rush and switch to hydralazine nitrate soon on, unless the patient really, as Dr. Saeed explains, worsened kidney function or hyperkalemia. Now, what is our target in ACR after start treatment to be less than 30? Do we have a target urine albumin?
Well, actually, most of the studies showed that only 30% reduction of protein. So you don't expect that to go to normal, okay? Yes. I think, as I explained in my presentation, it's really multifaceted approach. You have to block all the segment in order to reduce the proteinuria. So even, for example, diabetic control will reduce proteinuria. ACE or HARB, decrease blood pressure, weight reduction, dietary issues, and also the use of SGLT2, also the use of finerenone. So it's many faceted. It has to be saturated in order to decrease proteinuria. But nobody said that finerenone will abolish proteinuria completely.
And my understanding is, even if it reduces, you will still maintain the patient on finerenone. It's a maintenance drug, and not
because the value is outside just the proteinuria. Proteinuria is really secondary. It's not really. That's right.
And I think that is my probably final question that I would like to hear from both of you. Both of you touched on the role of inflammation and fibrosis in diabetic kidney disease. How does this uniqueness of finerenone affect, and how do you see that going forward in the management of our patients?
Hussein?
Well, sure. I mean, of course, if you look at the preclinical studies and how this actually reduced inflammatory markers, which we don't really do in clinic that much, probably, I mean, the most we'll do is CRP or so, yet these were reduced. So what we reassure patients is that even if we don't see a reduction in the urine albumin creatinine ratio, even if we don't feel anything that's changed, we know in the background there is actual benefit that is happening. There is actual protection taking place in reducing the progression of kidney disease. So that is probably how we would address the patient with.
Yeah, Dr. Saeed, you want to add?
Yes, thank you. Actually, anti-inflammatory it's not a new idea. It's a really long idea. And we know about actually inflammation and sclerosis and diabetic kidney disease. And I'm sure it might occur also in some other organs. But the question right now, do you have any other studies which will support reducing the inflammation? We have actually pirfenidone has been used in the kidney. Diabetic, it's really failed. We have used paradoxolone, also methyl, which didn't work well. Or there's another randomized control trial called Beacon study is really been going on right now. But I think the idea of the novel idea of fibrosis and inflammation, the only successful study is really the finerenone study. And regarding whether you have any markers, I'm sure there is some markers of this one can be tackled, but it can be used by proteomics, and it's not up to what you call for clinical use right now. For example, interleukin 17 has been looked at, one of the markers, okay, and there's some study working on this interleukin 17. So some other markers, cytokines really can be touched by using the proteomics in order to define the inflammation is one. But I'm sure, and I can tell you, I mean, from my looking at how science evolved, in the next 10 years, probably, you'll have markers checking these things better than looking at the albumin.
Well, that was excellent. It was a real pleasure having such a marvelous and amazing discussion, opening the door for new pathways and approaches to our patients, our dear patients. Thank you very much. I would like again to thank our eminent speakers, thank our organizers, thank our sponsors for having such a nice event. in the evening of Ramadan. Hope to see you next time physically inshallah. ويعطيكم العافية والسلام عليكم ورحمة الله وبركاته.
شكرا دكتور وليد، شكرا.
يعطيكم العافية. شكرا لكم جميعا.
جزاكم الله خير.